Hello, my name is Dr. Matthew Posen, and thank you for watching this poster presentation. This poster is entitled Downstream Without a Nidus, a non-aneurysmal ascending aortic thrombus resulting in STEMI, and details an interesting case of a patient that developed an aortic thrombus in non-typical conditions. This poster was prepared with the assistance of Dr. Valentina Turbay-Cabellero and Dr. Colin Coughlin under the guidance of Dr. Amir Naqvi. To begin, aortic mural thrombi most typically form in the setting of aneurysm or dissection in the abdominal aorta. Additionally, coronary artery embolism is a rare and under-recognized cause of acute myocardial infarction associated with high mortality risk. For this poster, we present a unique case of a coronary embolism that resulted from a thoracic mural thrombus in the absence of aneurysm and dissection or traditional hypercoagulable risk factors. Our patient was a 39-year-old female with past medical history of untreated hypertension, morbid obesity, tobacco use, and daily marijuana use that presented with a chief complaint of sudden onset, sharp abdominal pain after bending from a sitting position that radiated to her chest and left arm. This pain was associated with shortness of breath, nausea, and 3 episodes of emesis. The patient was given 324 milligrams of aspirin and nitroglycerin by EMS with the presumption that this was a myocardial infarction. On arrival to the emergency department, the patient's blood pressure was elevated to 166 over 131. High sensitivity troponin was initially 26 nanograms per liter, but later uptrended to greater than 16,000 nanograms per liter. Electrocardiogram revealed ST elevations of the anterior leads concerning for acute ST elevation myocardial infarction, or STEMI. Emergency coronary angiogram was done but did not reveal any coronary occlusions. This is believed in retrospect to be due to the STEMI being part of a minor coronary vessel branch. Computed tomography angiography, or CTA, of the chest was ordered, revealing a small intramural thrombus in the posterior wall of the distal ascending aorta with no definite evidence of aneurysm or dissection, seen on an initial CTA or repeat CTA. Transthoracic echocardiogram revealed hypokinesia of the basal anteroseptal, inferoseptal, and mid-inferior walls consistent with septal infarct. This acute septal wall infarction pattern was confirmed with cardiac magnetic resonance imaging. As seen on the echocardiogram, you can see the mural thrombus in aortic arch seen here. Additionally, a possible aortic dissection flap was also visualized. Treatment was started with intravenous heparin drip with later addition of enoxaparin, clopidogrel, and aspirin. Due to the size and location of the thrombus, it was determined that the patient was not a candidate for surgical management or catheter thrombectomy and was instead treated with medical management via warfarin and dual antiplatelet therapy. To wrap up, this case illustrates a patient with non-classical ascending aortic mural thrombus formation that resulted in embolic STEMI. Aortic mural thrombi formation is most commonly associated with dissection or aneurysm of the aortic wall and is very rare in the absence of these two predisposing conditions. The aortic thrombi formation is additionally associated with risk factors of smoking, steroid, oral contraceptive use, and a hypercoagulable state such as pregnancy or collagen disease. It is our belief that this patient's presentation was precipitated by her untreated hypertension causing a focal intimal injury that provided a site for thrombus formation in the setting of her cigarette and marijuana smoking risk factors. This patient was treated conservatively with medical management due to the small size and location of the mural thrombus. Due to the rare nature of this condition, treatment guidelines have not yet been set. Studies of treatment modalities in similar cases have found that patients treated with anticoagulation as the primary treatment had persistence of the thrombi in 38% of cases and recurrent embolization in 21% of cases, which were then managed with aortic surgery. For this reason, open aortic surgery may be the superior treatment modality in this rare condition. Thank you for watching this